Welcome to The Scoop from the Lurie Cancer Center's Adolescent and Young Adult, or AYA Cancer Program. We bring together AYA cancer survivors and experts to answer important AYA cancer-related questions. We hope you enjoy the conversation today. Hello, everyone. Welcome to The Scoop today. We're so happy that you're here. Today, we are talking all about palliative care and cancer. And so we're going to start with a few introductions of who I have with me. I am Bryn Fowler, and I'm the Adolescent and Young Adult Program Coordinator at Northwestern and Lurie Children's. Tina, do you want to go next?
Yeah, hi, I am Tina Chip, and I am a two-time cancer survivor, 31 years and 26 years. And I also serve on Board 39, which is an amazing group of folks that we've all been diagnosed with cancer before the age of 39. And been part of the AYA, which is the Adolescent and Young Adult population, for now over 31 years.
We've loved having you be a part of it, Tina. Thank you so much.
I love it. Thanks.
And Melanie?
I'm Melanie Smith. I am a palliative care physician at Northwestern.
Awesome. So Melanie, we have just a few questions for you today, and I hope people find this conversation helpful. So Melanie, maybe we can just start with a definition. Can you just define what palliative care means for us?
Yeah, and I'll say I do a lot of defining palliative care, especially in the first times I meet with patients and families, because I think there's a lot of baggage with the term. But palliative care is really specialized medical care for people living with serious illness. We focus on symptoms and the stress of illness, managing those, and also managing the symptoms or side effects that come along with treatment. Really, our goal is to improve quality of life for both patients and their families. So we try and broaden, the person that we care for, not just the patient, but recognize that, they come as a package, and their families, which may be close friends, maybe caregivers, are also affected by this. I think the other part of that means that we do a lot of exploring of how a patient and their family defines quality of life, because we want to take their values and concerns into consideration and adjust or make sure that their care plan really honors what's most important to them, honors their quality of life. So you can probably see from that definition that it's not just medical, and that's why we really are an interdisciplinary team. At Northwestern, our team is doctors, social workers, chaplains, nurses, nurse practitioners. Other places, there's always going to be some variation of that, but those are usually like the core members of a team. And at Northwestern, we have an inpatient team, so seeing patients in the hospital. We have an outpatient team, seeing patients in clinic or in the office. And in Chicago, there are also some home-based palliative programs, but they are affiliated with Northwestern.
That's really helpful.
Thank you for that definition. I can tell you, when I would hear the words palliative care, honestly, I thought it was only for people that were dying of cancer. And so I put it out of my mind. So you did a great definition, but can you help dispel the myth that people think, well, I don't even have to think about that, or if they're talking to me about that. The other thing is helping understand what the difference is between palliative care and hospice. Because I know I too was part of the group that was very confused about it.
Yeah. And I think part of that is, palliative care has changed a lot in the last few decades. It's really an emerging field, and our definition and our patient population has changed over time. But palliative care is really appropriate for anyone with a serious or progressive illness. And I will say that palliative care varies a little bit institution to institution, mostly based on their workforce and really how they're situated. So palliative care is often housed in a different department. So at Northwestern, we're housed within hospital medicine. Some places are housed within oncology. And those places, they may just be oncology patients. But we will see, anyone with a serious illness. I think we're most appropriate for patients who either have symptoms from that illness that need to be managed, or patients that, even if they're not dying of their cancer, they really want a plan. right? They have prognostic questions. We're just like, I'm hoping this goes really well, but I also want to plan for the what if. And those are the patients that we're really helpful for. And also, regardless of the stage of your illness, you might be going through some pretty intense treatments. So a team that focuses on managing symptoms and side effects can be pretty helpful when you're going through some rough symptoms and side effects. So we're really not just for patients near the end of life. We see patients throughout the course of their illness. And studies have shown, there's a major study of patients with advanced lung cancer, that patients in the early palliative care arm not only had better quality of life, they lived longer. And I think at least part of that is, we help them make good decisions about their treatment, but we also can help them tolerate treatment. So I think that we can be really helpful for patients much earlier than we're typically thought of. Hospice is in that palliative care umbrella. So I think there are a reason that we're associated, but palliative or hospice is really like a very narrow part of that umbrella. For instance, I don't really do hospice at all. I have some hospice training, but hospice is like the most intense palliative care that insurance will cover. It's really an insurance benefit designed to care for patients at home near the end of life. So they do a lot of the stuff we do, right? They focus on symptoms. They're an interdisciplinary team that also wants to support the family, but they really are restricted to near the end of life. So we are very distinct.
Yeah. So you've talked about how it's kind of this interdisciplinary group, and you've talked about some of the applications of palliative care, but can you give us maybe some examples of some issues that might be addressed kind of specifically in the cancer world?
Yeah. And I will say, I see almost solely cancer patients. I definitely see some patients that don't have cancer, but I am mostly embedded in the cancer clinic at Northwestern. And I like to divide what I do into 3 categories. So first category is symptoms. So, just exploring what symptoms or side effects patients are having. So symptoms of their cancer or side effects of their treatment. And usually using medications or adjusting their medications to manage those symptoms. Sometimes, working with oncology to think like, wow, like for instance, like their back is really hurting them right at this specific location. Have we thought about radiation to that, that location? So that would come up frequently. Or, I really think a nerve block would be helpful for this patient. I don't do nerve blocks, but I can certainly help arrange it. So we have more training in the medications to manage symptoms, but also in some of the interventions that can be helpful for symptoms. Then support. So in terms of the category, symptoms and support. So emotional, spiritual, even logistical support. So, recognizing that cancer is more than a physical symptom, right? Like it is a huge emotional blow. It's a big adjustment to just, live with cancer, to think about ongoing treatment. Spiritually, it can be pretty devastating and like really challenge just your understanding of yourself, God, spirituality. And I think support is really where the interdisciplinary team comes into play. So that's where, we'll get our social worker and chaplain involved, often doing a group visit, but then sometimes, like I'll leave and our social worker will stay, or, maybe I see a patient every other visit and the chaplain is seeing them every visit, which is really working and making sure we're addressing, every facet of a patient and what they're going through. Along with that, just because this is what we do, we have more practical knowledge of what is feasible at home, like what services can you really get at home? What equipment can you really get at home? So sometimes just practically speaking, like physical support, like we have a lot of knowledge of like, how do we get this? Is insurance going to cover it? If not, are there other ways to get it? Or how much is it going to cost? So, a lot of, just like thinking, again, to me, it's just like thinking of outside the box, but also it's just thinking about all the ways to support someone. And then
that really holistic.
Yeah, hopefully.
Mm-hmm.
And the third part is planning or advanced care planning, which is kind of a difficult thing to define. But these are those conversations about what is quality of life for you, right? What gives your life meaning? What brings you joy? Are you able to do those things? Why not? What do you worry about, or what do you really want to avoid? Like, let's make sure like we're planning for all the good things and making sure we avoid those things that are really important for you to avoid. And what are your goals? So, you know, like, I love when someone tells me, like, I have this event that's really important to me. And like, of course I want to like do chemo and get all my treatments, but like, I really want to feel good on this day. How do we make that trip or that event successful? So those things are really important. So just really thinking about all those things that make you you and that are really important to you to either make it to or to avoid, and planning for that. Sometimes it means like pushing back chemo a week. Sometimes it means adding a few extra medications so that you feel extra good for this event. And then on the other side, sometimes it means making sure that your family understands what's really important to you in case they're ever in the position where they have to step in and make decisions for you. If there are certain people that you want to help you make those decisions, making sure we've done all the correct documentation, often that's a healthcare power of attorney. And then, you know, this isn't a major part of my job, but, you know, sometimes it is, again, thinking about the what if and preparing for worst case scenarios too. And I think sometimes this is even more relevant for young adults, especially, you know, people with young children. And sometimes it's like, I'm doing everything I can to get through this cancer. But I know this is a bad cancer, and I also want to plan and think about what if I die of this cancer. And I think what we've found and what my experience shows me is that, you know, some people are really scared to have those discussions, right? Who wouldn't be scared to have that discussion? Yeah. But sometimes having it, just like, it just takes that burden off of you because you've like said it. You've maybe done the paperwork, or you've at least talked to your family. And so like, it's not this burden weighing you down. Like, you still don't want that to happen, but at least it's out there and you're prepared for it.
Yeah.
And we often, go ahead.
No, go ahead.
I just think, like, hearing all of those things, I'd probably be like, oh gosh, like a palliative care visit sounds really heavy. We want to follow patients over time, develop a relationship, and we do not do it all in one visit, right? And sometimes we only do 2 of those things, or only 1 of those things, even over the course of someone's, like, you know, palliative care visits, because sometimes they only need 1 of those things. But we're there, and I try to introduce it just so you know that, like, that is something I can also help with. Maybe we don't want to do it today, but know that that is something we can do.
So that brings me to a question. I mean, when is it the right time, you know, for patients and families to be made aware of palliative care, you know, what it is? And does this like come right in the beginning? Does their cancer doctor have to do a request for you to come in and talk to the family? And in the age of telemedicine, are you able to do some of these visits via telemedicine with these patients battling cancer?
Yeah. So we are doing a ton of telemedicine. I think a lot of the practices volumes were down in like March and April and May, and ours were not. These are definitely a lot of this stuff you can do like by talking. Some of the symptom stuff is better in person. You know, sometimes I want to like examine your abdomen or examine your back, but you know, emotional support, we can do a lot of that by video or even by phone. It is a really difficult question to ask, when should we get involved? That is a question a lot of practices are asking themselves across the country. You know, some places it's a check mark, like an automatic palliative care referral based on cancer staging. I don't really like the check mark or the automatic consult because again, this is patient-centered care. So I think, some patients really don't need specialized palliative care ever, right? Sometimes they have a great relationship with their oncologist, or they don't have severe symptoms, or they've already done all this planning, and they really don't need us. And some people need us really early on. Some people need us when they get, before they get cured of their cancer. So I think hard indications, times that palliative care definitely should be involved, are when someone has significant symptoms that their other specialists, so in this case, their oncologist, is having a hard time managing. If this is a curable cancer and we're getting involved for symptom management, we can sign off. Or, every once in a while we see a patient with significant symptoms who we don't think we're the best team, the best fit to manage those symptoms, but we can be honest with you and tell you, right? There's no harm in that conversation. And then patients that just really want a plan. Patients where this is anxiety provoking, they have a lot of questions about prognosis. We should get involved early. It doesn't mean we'll have to see you every week for the next 4 years, right? But we can see you early on, help you clarify these things, and maybe you don't need us after that. So I think those are two big indications. I took some notes. Let me make sure I didn't write.
So let me ask you about that. What about those patients that are in the community setting? They're not in a system like Northwestern. What do they do? And they're in a small private practice where there isn't someone like you. Now with telemedicine, what are their options?
Yeah. Telemedicine, does make it easier. So I think, and I think we're having a question about insurance later, but in the age of telemedicine, you may be able to reach out to a palliative care program at another institution to get an opinion. Sometimes there are issues getting full access to your chart. There's also a lot of great websites out there for you to start exploring on your own.
Yeah. As you were talking about when palliative care should get involved, I just had a quick follow-up question of, I know this is hard to make a generalization around this, but do you, in your experience at Northwestern, or even things you hear outside of Northwestern, how adept do you think oncologists are, or maybe aware is the better word, how aware do you think oncologists are about palliative care to make those referrals?
I think my experience at Northwestern is really good. But Northwestern also has one of the oldest palliative care programs. We've been around since the 80s here. Princess Di actually visited our palliative care unit. So we are really embedded at Northwestern. And I feel like there is a lot of comfort with us. And the providers at least don't have that. They don't see all the baggage with the palliative care term that you might see at other institutions. So yes, I think that is a downside of not having the automatic consult, is that it does rely on the provider, the oncologist, to say, we need palliative care here. And just like I think any other human being, to admit that you need help managing some of these things can feel like a bad thing or a weakness. So that may also delay consults for people that aren't comfortable with incorporating palliative care early. It's another reason for patients to be their own advocates, to do as much reading as they can, and to request it, right? If you feel like this is something I want to do, maybe my oncologist doesn't feel comfortable with it, or I'm feeling a little bit of hesitation, you can still call us and we can help you navigate it, right? Hopefully we are experts in communication. So that doesn't mean just communication with patients and families. We're pretty good at communicating with our colleagues and getting ourselves in, even if we're not on the floor.
That's great.
So I have a question. You mentioned that there's multiple parts. It could be a chaplain, yourself, social worker. What if someone doesn't want? Do they have to do all of it? Or what if they're maybe not wanting to meet with a chaplain or not meet? Is it okay so they can kind of craft it to what their needs are?
Yeah, definitely.
Okay.
Yeah, no one, because also that can be overwhelming. Like, wait, you have a team of like, whatever, 6 people. No, it doesn't mean you have to see all of us. We try and, work with you and your family to determine like what members of the team do you really need. And sometimes you need certain members at certain times.
Mm-hmm.
Yeah.
Right.
Yeah, that's so true. And can we circle back to the insurance question for a minute and just talk about, I know this is another thing that's hard to generalize, but what coverage generally looks like for these services?
So usually palliative care is covered just similarly to any other specialty care. So like similar to seeing a pulmonologist or even an oncologist.
Mm-hmm.
So usually, so often people don't even need a referral to see us, but sometimes they do. If you need a referral to see a dermatologist, you may need a referral to see us. At Northwestern, at least, there is like a little screening process. So we won't schedule an appointment with you unless we've worked out that you're in network. Okay. And you'll see like some people get exceptions to go to a certain oncologist to treat their cancer, and they just have that insurance exception for that oncologist. Mm-hmm. But sometimes that comes up like 3 times a year. It's not very common. And in those situations, we often find a workaround. We often insurance approves our involvement as well. But sometimes we do need to figure out like, oh no, actually only the oncologist is in network, but we'll find you a palliative care provider that is in network. I mentioned earlier home palliative care. Mm-hmm. If someone does elect to do home palliative care, there are a lot of different agencies, at least in Chicago. So usually you'll have to find the agency that's in network. So that requires a little bit of navigating.
Mm-hmm. Yeah.
So I have one last thought and question is, it can be overwhelming, a lot of information when you're diagnosed, and then treatment and all these different options. I know palliative care is so important because it's meeting me where what I need at the time, beyond just, giving me treatment. It's what else my body may be needing. But how do I explain it to my family? Are there booklets out there? Something simple? Because I know for me, some days I didn't want to talk to anyone except my nurse when I was an inpatient a lot. Because she knew what I was going through. She understood. They'd be like, I don't want any visitors today. So I think it can be overwhelming for us going through the cancer because unless you're in our shoes, it's really hard to understand. So just one less thing we'd have to worry about. What would be the best way to talk to our family and do that?
So hopefully we did design a new sheet to go in like the Lurie Cancer Center booklet. So hopefully there's a little blurb in there. But really, I think focusing on, this is a team that I want to get involved in my care to help manage my symptoms and improve my quality of life. Right? That's palliative care.
So keep it simple. Keep it real simple.
Right? Yeah. And, your family may give pushback. You're like, well, palliative care is hospice. And you can say, it's not. Like, really, they're here to help manage my symptoms and improve my quality of life. I need this. Right?
Well, this has been so helpful to just learn more about palliative care and know how many patients could benefit from this and probably have misconceptions. So I hope that it's helpful for others. Melanie, if people want to learn more about palliative care, even get in touch with you or someone on your team, are there suggestions you have of how they do that?
Yeah. So you can definitely call us. Our number is 312-926-0001. If you have questions about whether you're appropriate, I'm not sure if I want to see you guys or not, we can help talk it through it with you. There won't be any pressure to see us. CAPC, CAPC, so the Center to Advance Palliative Care, is a great resource. They really, talk about what palliative care is, can help with resources. I think that's another great website. And then, like we talked about earlier, I can send you some links for just some of the websites that help you a little bit with the planning piece, especially if you're like, I don't really know if I want to meet with a palliative care team, but I do want to start talking about these things with my family.
Okay, that would be great. Yeah, I would appreciate if you do that.
Yeah.
Well, I want to thank you both so much for your willingness to talk with us today. I know others will really benefit from hearing this conversation. So thank you so much.
Thank you. Thanks.
Today on The Scoop, we hope you enjoyed our conversation and learned something new. If you want to hear more of these in the future,